Welcome to our video on tubo-ovarian abscess and toxic shock syndrome. Let's get started. Here is our overview slide. Let's begin by discussing tubo-ovarian abscess. With regards to tubo-ovarian abscess, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's start with the definition. Tubo-ovarian abscess, or TOA, is an inflammatory mass involving the fallopian tube, ovary, and sometimes the bladder or bowel. As for the pathophysiology, it's a complication of pelvic inflammatory disease. It usually is a polymicrobial infection. Commonly isolated pathogens include E. coli, Bacteroides fragilis, Prevotella, Streptococcus, and other anaerobes. Risk factors include multiple sexual partners, inconsistent use of barrier contraception, a prior history of pelvic inflammatory disease, those ages 15 to 25, and having a partner with a sexually transmitted infection. Okay, moving on, now let's discuss the clinical features. Just like with pelvic inflammatory disease, these include fever greater than 38.3 degrees Celsius, pelvic pain, mucopurulent cervical discharge, and an adnexal mass on pelvic exam. Okay, moving on to diagnosis. Diagnosis of tubo-ovarian abscess is based on the combination of clinical symptoms, pelvic exam showing an adnexal mass, and the typical ultrasound findings of a complex mass with cystic and sometimes solid components. Treatment of TOA depends on the patient's clinical course and characteristics. Specifically, if the woman is premenopausal, hemodynamically stable with no TOA rupture, has had an abscess with a size of less than 7 centimeters and adequate response to antibiotic therapy, then antibiotics alone are sufficient. However, if the patient has no response to antibiotics and no clinical deterioration, then we perform abscess drainage in addition to antibiotics. Finally, if she has no response to antibiotics and she is clinically deteriorating, then we perform an open surgery in parallel with antibiotics. All right, let's try a question. A 45-year-old female comes to the physician due to left lower abdominal pain. She initially had generalized pelvic pain, which lateralized to the left side 3 days ago. She is sexually active with her male partner, but they do not use any contraception. Vital signs are significant for a temperature of 40 degrees Celsius. Her white blood cell count is 25,000. Pelvic ultrasound shows a left ovarian mass with cystic and solid components. What is the best management of this patient's ovarian mass? All right, this patient has left lower abdominal pain, a high fever, and severe leukocytosis. She's sexually active with her male partner, but they do not use any contraception. This presentation is most consistent with PID. Her pelvic ultrasound shows a left ovarian mass with cystic and solid components. This mass in the context of PID is most likely a tubo-ovarian abscess. And as we just discussed, this is treated with broad-spectrum antibiotics with or without abscess drainage or potentially surgery, depending on the response to the antibiotics and clinical status of the patient. So the answer to the question is antibiotics plus or minus drainage. Okay, moving on to our next topic, let's discuss toxic shock syndrome. Toxic shock syndrome, or TSS, is a systemic inflammatory condition. The most common cause is Staph aureus, although it can also be caused by strep pyogenes. Okay, now let's discuss the pathophysiology. In order to make this more easily comprehensible, let's draw this out. Here we have a macrophage and a T helper 1 cell. Macrophages, being antigen-presenting cells, have MHC2 molecules on their surface, while T helper 1 cells have T cell receptors on their surface. Now, toxic shock syndrome toxin 1, or TSST1, from Staph aureus, or erythrogenic exotoxin A from strep pyogenes, are superantigens. In other words, they cross-link the beta region of the T cell receptor of T helper 1 cells to the MHC2 molecules on the macrophages outside of the antigen binding site. This causes excessive release of interleukin 2 and interferon gamma from Th1 cells, and the release of IL-1 and TNF-alpha from macrophages. All of these cytokines being released results in what's called a cytokine storm, and this in turn causes shock. So again, returning to the pathophysiology, you can see this all written out here on this slide. Okay, moving on to risk factors. Toxic shock syndrome caused by Staph aureus is associated with prolonged use of vaginal tampons and nasal or wound packing because retained blood allows Staph aureus to proliferate and produce the toxin. On the other hand, the toxic shock-like syndrome caused by strep pyogenes is associated with painful skin infections such as erysipelas and cellulitis. Okay, moving on, now let's discuss the clinical features of toxic shock syndrome. It's characterized by fever, vomiting and diarrhea, a desquamating rash, and end organ failure. End organ failure may manifest with acute kidney injury, altered consciousness, acute liver failure, and muscle damage. Here is an image of a patient with toxic shock syndrome. Hopefully you can appreciate this desquamating rash, which we can see on her hand. The diagnosis of toxic shock syndrome is based on the combination of clinical symptoms, known risk factors like vaginal tampon use, nasal or wound packing, and the laboratory findings indicating end organ failure. These include increased AST, ALT, and total bilirubin indicating acute liver injury. Increased creatinine kinase suggests acute muscle damage, while increased BUN and creatinine indicate acute kidney injury. Okay, now let's discuss treatment. We should urgently remove any packing from the wounds or tampons from the vagina. After that, we need to start wound debridement to halt Staph aureus replication. We also need to treat the shock with IV fluids and add vasopressors if needed. Finally, IV antibiotics should be administered. If an MSSA infection is suspected, we can use nafcillin or oxacillin and clindamycin. If, on the other hand, a MRSA infection is suspected, we should use vancomycin and clindamycin. IV immune globulin may sometimes be used, but this is rare, and we use this in patients who are unresponsive to fluids and antibiotics. All right, let's wrap up with the final question. A 34-year-old female is brought to the physician by her husband due to a skin rash and diarrhea that started 8 hours ago. She has vomited several times on the way to the hospital. She has a past medical history of heavy menstrual bleeding for which she uses vaginal tampons. Her last menstrual period started 2 days ago. Her vital signs include a temperature of 40 degrees Celsius, a blood pressure of 60 over 40 millimeters of mercury, a heart rate of 150 beats per minute, and a respiratory rate of 25 breaths per minute. Her white blood cell count is 30,000, AST is 4,000, ALT is 3,000, and total bilirubin is 6. Her BUN is 90, and creatinine is 4. Which of the following is the best initial step in the management of this patient? A. Intravenous normal saline. B. Wound debridement. C. Intravenous vancomycin and clindamycin. Or D. Intravenous immune globulin. All right, this patient presents with a rash, diarrhea, a high fever, severe hypotension, tachycardia, and leukocytosis. She has a past medical history of heavy menstrual bleeding, which started 2 days ago, and she uses vaginal tampons during her period. Her ALT and AST are extremely elevated, likely due to ischemic hepatitis. Additionally, her BUN and creatinine ratio is more than 20, indicating pre-renal acute kidney injury likely due to shock. All of these findings are consistent with toxic shock syndrome. This question focuses on the best initial step in the management of the patient. Although we would perform almost all of these interventions at some point, the very first intervention is to give IV normal saline to increase the patient's blood pressure. Remember, whenever we have a patient with a life-threatening condition, we always think of our ABCDEs first. A for airway, B for breathing, C for circulation, D for neurological defect, and E for exposure. This patient first needs circulatory support. So the correct answer is option A, intravenous normal saline. Recall from this slide that we can give IV fluids and vasopressors to help treat with shock. Okay, let's discuss why the other options are incorrect. Option B, wound debridement, is incorrect because it would be performed after giving IV normal saline and antibiotics. Option C, IV vancomycin and clindamycin, is incorrect because they would be given after administering IV fluids. Finally, option D, intravenous immune globulin, is also incorrect because it's rarely used and typically only given if patients are unresponsive to fluids and antibiotics. So again, the correct answer is option A, intravenous normal saline. And that concludes this section.